You're still watching Good Morning Nigeria on the network service of the NTA. And just before we introduce our guests to get into our conversation on managing asthma, let's take this background report. It was put together by Ibrahim Belogunda.
Asthma is one of the long-term diseases that affect the airways in the lungs. It inflames the airways, making them narrow, producing excess mucus, making breathing difficult. Asthma affects people of all ages and is one of the most common chronic respiratory disease worldwide. In Nigeria, asthma is increasingly recognized as a major public health concern. Although medical experts say asthma cannot be completely cured, it can be effectively controlled with proper treatment, lifestyle adjustment, and regular medical care. People living with asthma can lead healthy and productive lives when the condition is properly managed. During an asthma attack, the muscle around the airways tightens, the airways lining swells, and mucus production increases. This reduces airflow and causes breathing difficulty. Symptoms may vary from person to person and can range from mild to severe. Common symptoms include wheezing, shortness of breath, chest tightness or chest pain, persistent coughing. Asthma symptoms may come and go, and attacks can occur suddenly. Several factors commonly trigger asthma symptoms in Nigeria, including dust during the Harmattan season, air pollution, cooking smoke, tobacco smoke, respiratory infections, urbanization, limited access to healthcare services, and even physical exercise in some individuals. Effective asthma management involves the proper use of medication, avoiding triggers, patient education, and regular medical follow-up. However, Nigeria continues to face several challenges in asthma care, including poor access to healthcare, high cost of medication, self-medication, limited public awareness, and increasing environmental pollution. How aware are Nigerians about asthma? What misconceptions exist about asthma in Nigeria? And how can patients better manage the condition and improve their quality of life? These are some of the critical questions we will explore today on Good Morning Nigeria as we engage our distinguished guests in this important conversation.
All right, many thanks, Ibrahim, for the background report. Let's get into the conversation now. We have seated in the studio to talk about the topic, managing asthma. We have Dr. Enwata Nehikai, consultant physician and pulmonologist from the University of Abuja Teaching Hospital, Gwagwalada. Many thanks, Doctor, for joining us.
Thank you very much.
All right, also here is Dr. Ahmed Sani Bala, Department of Family Medicine, FMC Abuja, CEO, Vital Aid Medical Foundation. Doctor, it's a pleasure to see you again.
Thank you very much for having me again. Good morning.
And via Zoom from Gwagwalada, we have been joined here in the FCT by Alexander Agada Ako, Associate Professor of Medicine and Consultant Physician, also of the University of Abuja and University of Abuja Teaching Hospital. We are glad you could join us on this conversation.
Thank you very much. Good morning, viewers.
And finally, but by no means the least, via Zoom from Kano, is Dr. Hassana Abubakar Imam, Consultant Pulmonologist at the Aminu Kano Teaching Hospital. Very welcome to the program.
Good morning, all. Thank you for having me.
All right, let's begin. Well, what did they say about ladies first? Perhaps let me play safe by going ladies first. And I'd like to ask, asthma is often described as a manageable condition, but people, still die from it. So why is this becoming this worrying situation, especially for Nigerians?
Yes, so asthma is quite manageable, and all it takes is awareness on the part of patients, caregivers, and including health workers. That is why we celebrate this day, World Asthma Day, which occurs every first Tuesday in May. So, and then aside from that, it's a day that we engage with policymakers, pharmaceutical industries and suppliers, to, reduce the cost of treatment, to make treatment more accessible and affordable. So you see, asthma at times is inherent, you can't really avoid it in the sense that when you have your triggers, stuff that, actually brings about your symptoms, you have no other choice than to treat it. So what happens is that, when you get exposed to these triggers, they could be dust, smoke, stress, exercise, and the likes, your airway narrows, and then you have no other choice other than to, use a medication that would open up the airway. So it's manageable in the sense that if you are well educated about your condition, and you know what triggers your condition, you could avoid it. So avoidance means no symptoms. So that's managing asthma. Secondly, unavoidably you get exposed and you have symptoms. You could use medication, but then the medications have to be affordable, have to be available, and then you should be able to use it, the right way. That's where the health workers come in: availability and affordability by policymakers, government, and the like. So yes, it's manageable. It's the responsibility of the health workers to actually educate their patients. Educating patients go a long way in helping managing any condition because they understand it. They know what to do. They know when to do what they're supposed to do. And they can volunteer, certain things to the doctor or the health worker that could even further help in managing the patient. So yes, it's quite manageable. Yes.
So, Imam, for your opening comments, let's get back in the studio. Dr. Nehikari, I'd like to find out those who are likely to have asthma. Okay, how does it originate? Maybe that's what I want to know. Okay. So is it that a child is born with the condition, or is it that it's something you pick up in life? And what are the early signs, really, of asthma?
Okay. Thank you very much for the question. So first, let's start with knowing what asthma is. So asthma is a chronic inflammatory airway disease, meaning that the problem is in the airway. So there are passages where air passes to the part of the lungs that is responsible for gaseous exchange. So for some reasons, which I will highlight, these airways or these passages become inflamed, meaning that they become swollen, they become narrowed, and there are some cells that line up this airway that produce excessive mucus, leading to obstruction in the airway. So these symptoms, they would include, for example, shortness of breath, wheezing, that is noisy breathing, chest tightness, and cough. And the symptoms, they vary in time and intensity, so meaning that they come and go. So who are the people that are susceptible? They are risk. So it can be that there's some genetic predisposition, meaning that these symptoms can be passed down from a parent to a child. Then there's also the effect of the environment. So that's why we always say there is an interplay between genetic and environmental factors. So if there's a predisposition of a child, for example, having asthma, and the child is exposed to a particular environment or triggers in the environment, definitely the child will start having symptoms. And we'll say most of these asthma cases, we see it predominantly in children. So children above 2 years, you start having symptoms, they start having cough, they are breathless when they're exposed to maybe dust, smoke, or strong smells, or even the weather. During cold seasons, they start having these respiratory symptoms of the chest tightness, noisy breathing. So it's not just enough to have the symptoms. The parents also have to take the child to the specialist to make a proper diagnosis, because it's not everybody that have the symptoms would translate to having.
Are you saying that if you don't have it genetically, you can't manifest it?
So in childhood, that's the typical way there's always some genetic predisposition and then the effect of environments. But however, in the adult population, those people that are exposed to a particular kind of job, it can be occupational. So if you're exposed to a part of like a type of job like you're doing spray painting, welding, or you work in a farm or you're a baker, there are some triggers, there are some things that will trigger that the asthma at an advanced age or at an adult age. So we call that is a different type of asthma, occupational asthma, which is different from the usual way, which is mainly genetic and then environmental.
Because I was going to say that recently a broadcaster died, somebody I know, you know, well into his 50s, and that he died because he had an asthma attack that he didn't recover from. And I'm wondering, this used to be with children, you know.
Yes, you get it from childhood, and you can have it till adulthood.
So it's not curable?
It's not curable, but it can be managed well. You can manage it very well, and you live a very good life with it. So it's manageable. There are drugs, effective medications that we can use to manage it.
All right, Dr. Bala, how early should asthma be detected, especially in children?
Okay. As he rightly mentioned earlier, there are some signs and symptoms that they manifest with, together with the environmental conditions now that would lead to the manifestation of these frank symptoms. So in dealing with children, you have to have a high index of suspicion because they don't even know how to express their symptomatology. The parents have to be very, very observant, especially if the parents themselves are asthmatic, because they can pass it easily to the children. And then there's an interplay between the environment and then the genetics. So for parents that are asthmatic, they have to have a high index of suspicion and keep an eye on their children. On the triggers that they, as parents, they know that it can trigger their asthma. The children would not know what triggered the symptoms, but you should look out for the symptoms of noisy breathing, and breathlessness, chest tightness, and as my consultant rightly said, you should refer to the hospital because they are very young children. Their pulmonary reserve and everything is very, very low. So the symptoms tend to be more severe in extreme of ages. So you look out for these symptoms once you notice the child is having a noisy breathing, especially at night, having excessive cough at night, having chest tightness, getting very breathless in normal childhood activities. Just normal activities would get the child very excited and breathless. So you have a high index of suspicion, and then you present to the specialist for the child to be fully evaluated and to ascertain whether those symptoms are actually asthmatic symptoms.
Now, you've talked about men, being very observant to notice this. So would you say that many cases go undetected in Nigeria?
So it depends on the presentation. Like in the highly urbanized areas, people tend to have access to healthcare. So when they have these symptoms, they present to the healthcare for evaluation. And when they meet the specialist, diagnosis is established based on the symptoms and full evaluation they present with. However, in places that have minimal access to healthcare, hard to reach communities in rural areas, many of these symptoms, they go undetected because of lack of education and the lack of access. They don't have the knowledge of what is asthma. They don't have the knowledge of what are the symptoms of asthma. So they tend to attribute symptoms that are of asthma to other things like common cold, spiritual attacks, attributing it to everything different. While in other places, even if they establish that, yes, something is wrong, there is difficulty in breathing, there is chest tightness, but then there is no access to a healthcare center where they would have access to a pulmonologist, or where they would even have access to a doctor that would evaluate them even at primary care level as a family physician, seeing a family physician at primary care level to establish the diagnosis of asthma, and then if it needs referral to a pulmonologist, there is no access there. So two things now contribute: the ignorance or lack of knowledge to what the disease is and its symptomatology, and then even after identifying that something is wrong, the lack of access to healthcare, it could also contribute to that, and then it would reduce the diagnosis. So most of the cases in those communities I cited are underdiagnosed.
Okay, they're underdiagnosed. So is it likely that you could defeat asthma even without medication? I'm just thinking, because for those areas that don't have access to medical care, what eventually happens if it's actually asthma? right?
Yes.
So I'm sure you tell us much later if what it leads to, whether it leads to death or whether they just somehow live above asthma. Let's get to Dr. Ako now, because when you spoke, you talked about people believing, or some people in certain places thinking that it's a spiritual attack. So I want to find out the biggest misconceptions about asthma. Dr. Ako.
Okay, thank you very much. Just like you have rightly said, that seems to be one of the major misconceptions about asthma, whereby the symptoms are frequently underestimated by even those who suffer from it. So they ascribe those symptoms to other issues that are contemporary to us. For instance, some people may link it up with one form of spiritual issues or the other. And then sometimes again, because people don't also recognize these symptoms, they go over the counter and treat with other things outside what is asthma. Now, but there are other misconceptions that are with it. Some people just believe that asthma is infective and can be contagious. Now, as a result of that, they don't want to be associated with the disease. But what we do know is that the disease is potentially not a contagious disease. People can acquire this disease from other people who have it. And so you see that it's a great thing that people don't want to be ascribed at all that they have the disease. Other misconceptions include even treatment. The other presenters have talked about the fact that the treatment is potentially manageable and the drugs are available. But the real challenge is that people link some of these medications to the fact that they are addictive in nature. What this means is that they just believe that once they start taking this medication, they will remain on it, or that the drugs in themselves cause you to stick to it all through your life. Well, we know that very well from all the agents that we use that traditionally they don't cause addiction in individuals who take them. And so you find out that those who have these kind of misconceptions will always not want to take the medication. And this seems to be the problem, like the doctor had spoken on. The fact that some of these individuals would rather prefer to take medications that are not being proper, that have not been ascribed to be used in the treatment, especially tablets. People just believe that when they are sick, they should take tablets or medication. So when you present to them basic medications that will work, that will cause less side effects in them, the traditional response is to reject those medications. So there seems to be a lot of misconception. That's why asthma education actually should be one of the major components of management of these patients. The reason why they don't turn up is that all of these misconceptions run through their mind, and the belief system kind of hamper their ability to seek medical care early enough to prevent death. Like the hosts have said, we don't expect anybody to die from asthma. That's honest truth. In this era, in this period where there are potentially available drugs that can treat it, nobody should die. Unfortunately, we know from statistics that a large people still die from it, and majorly it's because of these misconceptions. It's been reported that close to like 500,000 people die from asthma at some point in time or the other. And sadly, most of the deaths will occur in our kind of environment where resource distribution in terms of health is not equal. We talked about the disparity in terms of urban, rural, and so on. So misconceptions seems to be the major thing, and that's why a day like this is really a day that we should keep focusing on some of these issues. That beyond the public enlightenment and the mass campaign, but people should know that truly there's nothing wrong with this. It doesn't affect people. It cannot be contacted, and that the treatment is readily available. People can lead their normal lives and leave it to all through their life without much morbidity or sequelae, and the deaths can be avoided as much as possible. By and large, these are some of the few misconceptions people have generally with it. But sorry, I skipped something. You know, sometimes people always ask the question, can an individual overgrow asthma? That seems to be another misconception. Whereas, like Dr. Mwanta had illustrated previously, because the symptoms can be managed very well, you tend to find out that much later in their livelihood, they tend to have remission of their symptoms. And so what people describe as they outgrow or overgrow their symptoms. But in real sense, once individuals have this disease, it stays with them all through their life. But the symptoms can be managed and can go into a long period of remission without them really needing, sometimes even the medication.
What crosses my mind at this point is it possible for someone to have asthma and not know and eventually lead to death maybe much later in life? Because there was an experience of someone who died in his 50s, but nobody ever saw him or knew that he was dealing with asthma. So the question is it possible for the symptoms to be really minimal, and then eventually get to a height at a certain age in life? That's one. You talked about the fact that you're not dependent on medication. For those who use inhalers, maybe you talk to us more about what the inhalers do. There are reports that they have to be with it all the time. It has to be accessible. It has to be everywhere. So isn't that dependence on the medication? Isn't that a cause for concern also? Because, I mean, what's the guarantee you can always have it with you?
So thank you very much. Let me start with the first question. The issue of missing the diagnosis. The doctor in the studio had talked about the fact that people need to really get evaluated, and that seems to be one of the lack we have generally around. The truth is that there are other diseases that mimic or appear as if they are asthma, but for when you have a trained specialist, he's able to decipher between which is which. It's not normal, or it's not a norm for people to come down with asthma in later aspects of their life. Most asthmatics would have presented much earlier in life, as was previously spoken of by the doctor on stage. However, we know that there is a late onset presentation that can happen in a small fragment of people, which may be what you have probably described that. But it's important to know that in the older age group, it may be nice when someone is presenting with symptoms that look like asthma, that they should be properly evaluated. Sometimes people have heart failures. The heart failures may mimic what look like an asthma attack, really. And so this can be misdiagnosed. And so on that, misdiagnosis also is a real issue, really. And so the only way we can get around this is to get more people to find ways of seeking help and actually making correct diagnosis so that appropriate treatment can be administered to this patient. You have raised the second question of people being dependent on it, especially if you put together the fact that sometimes this medication may not be readily available. Again, I would like to approach it from this angle, the fact that while we're drawing our attention to this particular day, and in fact, the theme of this World Asthma Day is access to anti-inflammatory inhalers to everyone that have asthma, is still an unmet need. Now, the anti-inflammatory inhalers actually are like the gold standard, the mainstay of treating these individuals who have asthma. Now, the unfortunate thing is that, of course, we have in our part of the world the challenges of the fact that these drugs are not readily available, and even when they are available, getting access to them, it's an issue. And then what follows that closely is the fact that the costs. And so the reason why some individuals really don't stick to treatment is as a result of the fact that all of these factors put together are mitigating against them getting proper treatment and proper control of their symptoms. Of course, we keep advocating and keep asking. We're like Oliver Twist. In the Nigerian Thoracic Society have put up a strong campaign with regards to this. Most of these medications actually should be in our essential drug list. But as it is right now at the moment, these medications which can potentially control asthma are not in our health Insurance Act. And so a day like this is a day to draw the attention of policymakers and even people in the media to help in pushing this campaign so that people know that this disease is with us. The doctor from Canada told us that we have not less than, at least we have close to like 15 million people, which is a big number that probably will be suffering from or are suffering from the disease at the moment. So we really need to push this to stakeholders, even the pharma companies, because these drugs are not manufactured in this country. That's the other challenge. So we hope that with some of this advocacy and so on, we could get companies who can domicile and produce these drugs at home. So it makes the issue of supply chain, it makes the issue of availability and accessibility of these medications readily available for individuals who suffer from it. Our goal we still maintain is that nobody should die of asthma in this 21st century.
All right, Dr. Ako, thank you very much for the comments that you have made. Let me get back to Dr. Hassana Imam. And Dr. Ako had just talked about the dichotomy between, asthma in the rural and urban areas. In your experience, Dr. Hassana, how is managing asthma in the rural versus urban settings?
Yes, so ordinarily, which it shouldn't be really, you would expect a difference in care generally between the rural and urban area, where you have more quality care in the urban area than rural area. So there are a lot of factors that contribute to that. First of all, availability of health workers at that level, at the rural setting, and then availability of medication. So medications are not really accessible, and probably with the weaker economic strength in the rural area, probably they're not able to afford it where it's available. And then secondly, in the rural areas, you find out that most people are not that literate to be able to access knowledge, to be able to be educated, and for them to be able to understand, what asthma is all about. As I said earlier, educating the patient, the caregivers, and even the populace at large, goes a long way in managing asthma. Because in the rural areas, even in the urban areas, you find, that misconceptions about asthma, hinder care of asthma, even if the resources are available, the health workers, the medications are available. So yes, there is really a difference, but I would say that with such a day, actually pointing out such differences, actually making an effort to educate health workers, the urban and rural health workers alike, the populace, the urban and rural, particularly the rural populace, in a way that they will actually understand, and addressing the peculiar misconceptions they have in that particular area, and then advocating for availability of, the inhalers, and cutting down the price in inhalers and making them available everywhere, not just the urban areas, not just the rural areas, but urban areas as well. So generally, we have, a problem of availability. So yes, there is a difference, though, with the type of hospital types that we have, primary health centers, secondary health center and tertiary health centers at each level, being trained to see red flags, in patients generally, not just asthma, and are able to reflect, from the primary health center to the secondary, and then from the secondary to the tertiary. So a number of them eventually get to access care in, secondary and tertiary hospitals where the care and availability and, is better.
Dr. Imam, two questions come to my mind at this time, but I'd like our viewers to know they can be a part of this conversation. The number to send your SMS questions, whatever it is, about the topic of discussion is on the screen. So we want to read from you, either SMS or WhatsApp messages. That would be fine. Thank you so much. Dr. Bala, I'd like to get to you. Dr. Imam was talking about availability of medication. And I'm thinking, is availability the issue? Because when Dr. Ako spoke, he talked about not part of insurance. So I'm thinking, what's the cost of managing asthma? Considering the fact that it's a lifelong ailment, you have to keep managing, right? You don't get cured from it. So just give us a sense of what it would cost, really, for someone who has asthma to deal with the disease. And then Dr. Imam said secondary and tertiary hospitals can manage this. In most communities, what you have is primary health care centers. So I'm just thinking, the misconception about, people thinking is all sorts, not asthma. Is it as a result of lack of adequate medical facilities, really? To detect that it is asthma. Could that also be a reason why a lot of people are living with the condition and have not been diagnosed?
Thank you very much for the two questions. So I would start with the first question. So in asthma, the presentation is not like one glove fits all. There are different presentations. It could be an intermittent, mild, moderate, or severe asthmatic attack. So the drugs now, it depends on the stage of the asthma or the presentation of the asthma, right? So there are different classes of drugs. There are drugs that are used to control the asthma. There are long-acting medications that the patients would be on to control and stabilize so that it will prevent the triggers and then it will prevent the frequency of the attacks. And then there are drugs that we use as emergency. There are short-acting medications that will reduce the inflammation, relieve the airway, and both of them, they have different costs according to the different brands and all. So there's no specific cost that I would be able to quote and say that this is specifically what it would cost for the treatment of asthma.
But what's the average like?
The average, it depends, as I said earlier on, it depends on the presentation, it depends on the stage of the presentation of the asthma, whether you are dealing with a severe asthmatic attack, whether you are dealing with mild attack, whether you are dealing with an intermittent attack, or whether the patient is in the emergency room getting nebulized and all that. So the different brands of medications have different costs that you can't specifically quote the cost and say this is the cost. But as I said earlier on, it depends on the presentation, and then it depends on the brand of the medication that you're using. So this,
all right.
Yes.
Lack of medical facilities, could that be a major reason why we have undetected cases?
Yes, lack of medical facilities. As I mentioned earlier, specifically in the rural and underserved communities, you need some basic pulmonology tools to establish your diagnosis. You need some basic investigations to establish your diagnosis. And then you need, importantly, a trained healthcare personnel. It's not just everybody that makes the diagnosis of asthma. As Prof. rightly mentioned, different diseases in the respiratory system or other systems can mimic and present with symptoms similar to asthma. So you need, from the history, the examination, you need the expertise to decipher what is this, to rule out other conditions, to rule in other things that will make you align your diagnosis to asthma. You have to have it, and then other investigations to further confirm your diagnosis. So all these things now, in places where the knowledge is not readily available, the resources are not readily available, many conditions will either be misdiagnosed or underdiagnosed. So yes, lack of healthcare, and then the knowledge also and the qualification of the healthcare professionals plays a vital role in the diagnosis and then the subsequent management of asthma.
All right. Thank you, Dr. Bala. Now, Dr. Nwata, why does it seem that many people only take asthma seriously during an attack?
Okay. Thank you very much. So before I answer your question, I know Ms. Erin mentioned about the cost. So normally, in a month supply between 15 to 20,000 naira a month to get an anti-inflammatory inhalers. Previously, at the point when GSK, one of the big pharma companies, left Nigeria, the asthma drugs were up to, the inhalers were up to 35,000, 40,000 naira for a month supply. So you see that the cost is also a major problem that many Nigerians or many patients that suffer with asthma have to face, because just imagine someone who gets 70,000 or even 40,000. So he's using almost half of his salary to get this drug. So that's why we talk to the government agencies to help see how they can add these medications to essential drug lists, as Dr. Akko mentioned earlier, and also include it in the NHIS platform so that the Nigerians can access this drug, because they are usually life-saving. So your questions again.
Yes, I was asking, why does it seem that many people only take asthma seriously
when they have an attack? Okay, so it's just the education, health education, because if they are aware of this, as the way we are drawing attention to it, I think they will take their health more seriously, because really, as I said, these attacks, they are preventable. They're largely preventable. If you're on the medication that your doctor has prescribed for asthma and you're regularly on it, the chances of you having worsening or flare-ups of these symptoms is less or none. These medications, they are very effective to help reduce the inflammation in the airway, which is a major problem in asthma. It's not just the obstruction, it's the inflammation. And when the individual is exposed to triggers or things in the environment that trigger the attack, that's when they have the symptoms.
What are the triggers?
Okay,
I've heard trigger from everybody. What are the triggers?
So there are a lot of triggers. So typically, these triggers, they are mostly within us, within the environment. So triggers like, for example, smokes, dusts, strong perfumes, even the weather, seasonal asthma. Then in the house, there's what they call the house dust mites, which of course you see in beddings, in furnitures, then cockroaches, strong smells, emotions, most of them. So yes, strong emotions, like someone that is laughing or crying or very high elation. Some people can have attacks with that. So you see that each individual have their own triggers. They know what, most asthmatic, they usually know what bring on these symptoms. So what we'll tell our patient is identify your unique triggers, identify those things or those factors that bring up these symptoms. Then try as much as possible to work around them to avoid.
How do you avoid the triggers that are environmental? Because, in certain communities, environmental pollution is, it's what they live with every single day. So how do you now avoid, you won't go to school, you won't go to work. How do you avoid?
So most of the time, these triggers, they are within the home environment. So there are ways in which you can avoid, cleaning the house, use of face mask, maybe when you're passing through a very dusty place. It's just a way you walk around and around those things that you think would necessarily bring up these symptoms. But air pollution, for example, the individual cannot do anything about that because it's in the air. But the environment, the government agencies, there are agencies that are responsible for ensuring that this pollution is limited. So we can also advocate to these people to see that, these agencies, they look for a way to help mitigate this pollution, like burning in the environment, open burning, and some other things, flooding. There are many other things that would cause
fumes from vehicles.
Fumes, yes. So now we're talking about global warming. Let's go to clean energy. Let's reduce waste in the environment. So all these things, there are agencies that are responsible for looking into the environment to see, what is the level of pollution in the environment? Because if we can mitigate this, we see if there's a cleaner environment, the risk of having these attacks will be less.
What about cold?
Yes, cold is still part of the trigger. So I said weather. So in cold weather, you see that they start having these attacks, because once they inhale this cold air, the airway is already very hyper responsive to stimuli.
Fragile.
Yes. So when that inflammation is set up and they're exposed to cold, definitely there will be some triggers. So environmental. So if extreme heat, extreme cold can also be triggers
Economic conditions can also be triggers.
Yes, if you are stress is a trigger. So if you are worried about how to get food on your table, of course, it can be a reason to
You know,
have an
why
attack.
I looked at economic conditions could be that, someone who could have, if you could afford to live in a better environment where there's no smoke, where you can control the dust, I mean, to a certain extent, you'd rather live there than live in, a suburb or in a local community that's polluted and all of that.
Yes,
and again, the cost of medication, all of that could also be a factor. But you see, I want to understand something, because when we talk about asthma, what a lot of people know who don't have the condition, it's just the inhaler that we always get to hear about or see. Speak to us about what that does, right? The inhaler, right? What does that do?
Effect, okay.
And I've also heard reports that inhalers expire. So if you don't replace, or if you use it when it's expired, it doesn't have an effect. Or, I mean, just speak around people who currently have the condition and how they can manage themselves and also use their inhalers right.
Okay, thank you very much. So these inhalers are very effective tools or medications that we use in managing asthma. So these inhalers, they come in with the medication in it. So most of the time, there are different types of inhalers. So the commonly used ones are the meter dose inhalers, which have medications that help open up the airway. They call them a bronchodilator to open up the airway. Then there's also the other ones that have an anti-inflammatory medication, a steroid medication in them. So the Global Initiative for Asthma, GINA, which is a body that helps to give information or direction on how to manage asthma and also bring about awareness, has advocated that in effectively managing asthma, what is recommended is an inhaled corticosteroid containing medication that will reduce the inflammation. So this inhaler, they are quite effective. They go in to the airway and act locally. So we don't recommend systemic medication again. We don't say go and take tablets or go and take injection no, you go directly into where the problem is. And
so inhaler is what it is.
So it's what is recommended. And it's quite an effective and safe medication to use.
How often do you use it?
So it depends on the symptoms. So there are some patients that will have frequent daily symptoms or 9-time symptoms that will wake them from sleep or limit the activity.
And that's why it has to always be.
Yes, we recommend them that, okay, this group of people that have very serious symptoms, they should take it in the morning and take it in the evenings. You understand? But the other times that we say, okay, take it maybe 2 times in the morning, 2 times in the evening, or when you are having an attack. So these inhalers, they help to relieve the symptoms quickly and also help control the symptoms over time. So studies have shown that those people who take this medication regularly, they don't come down with worsening symptoms. They don't get admitted frequently like those who don't or who take other type of medications for asthma. So the recommended is an anti-inflammatory inhaler. That is a recommended medication.
So if someone doesn't have symptoms and doesn't use the inhaler for a certain period of time, can he or she still use the inhaler that was gotten in 2025?
No,
in 2026?
No.
Speak about that.
No, they are expiratory. Most drugs have
results.
expiratory validity period. So it has to be within the period that the manufacturer said you should use it for, so that it will be effective. And also even storing your inhaler. You store it, after use, you clean, there's a cap to it. Yep. You store it in a cool place to be effective. Because
in Nigeria, in a cool place, I don't understand. How is that possible?
Do you recommend putting it in the fridge, for instance?
No, not in the fridge. Like in a cool, dry place, like maybe in a cool, dry place, like maybe
if you
a shelf
need to move
in your
around
cupboard,
with the inhaler, like you have said.
put it in your bag. You can have a bag or a purse. So what I usually tell my patients, have like 2 inhalers. Have one, you can have one in your bag or have one at home. You should always go, because you don't know when the attack will come. You don't know when you are exposed to a trigger. You're coming out and there's serious pollution or dust or smoke and you start having an attack. Maybe those people, they didn't have symptoms, but when they're just exposed to triggers, they have an attack. And if they are not with their inhaler at that period, it will be difficult, because most of the time when the attacks come, they can't even talk. They can't even make a sentence. They are trying to, people are coming to, what's the problem? They can't even talk. And we've seen many people who have died.
But how
like
can
that.
people manage such a situation when someone is having an attack? Because in Nigeria, what happens, people just surround the person, some are taking pictures. I mean, we don't have basic first aid skills, you know. But speak to us, how, in case someone is having an attack and you suspect it's asthma, what can onlookers do? Okay,
so it's to draw, that's why the awareness is around, so that it's not only those that have asthma that should know about asthma education. The common man in the street should know how to identify that this patient is having wheezing, like noisy breathing, this patient is breathless, and that suspicion should be there to say, okay, yes, this will need a serious medical attention. The patient has to be rushed to the hospital, because there and there you can't do anything. So, but at least basic aids that you can do to tell the patient to try as much as to reassure the patient to calm down, and then quickly move the patient to the emergency for urgent attention. But you cannot manage those emergency in the streets. It has to be in the hospital. Yes.
All right. Let me get back again to Dr. Hassana. And I'm going to be asking, because this has come to mind due to the engagements with the other doctors, is asthma management in Nigeria more of a medical challenge or an awareness challenge, in your opinion?
Sorry, can you come again?
I said, is asthma management, is it more of a medical condition or an awareness? Is this a medical problem or an awareness problem, you know, from where you stand?
It still wasn't clear.
Okay, let me say it again. Is asthma management, is it a medical problem or an awareness problem from where you stand?
It's not clear. The network is, I think it's...
Okay, we'll get back to you once we can fix that. Let me get to Dr. Akko with it and you know, see what we get. Dr. Akko, if you heard my question, you know, perhaps you just respond.
Can you repeat the question?
As I said, is asthma management more a medical condition or an awareness problem?
Okay, I think if I got you correctly, it's both really. We must think about an awareness problem here because, like Kofol have ascribed to, education seems to be the real issue. And the education should be at various tier of our sphere of engagement. First, on the part of the patient, which we have talked so much about, and then even on the part of policymakers and regulatory agencies that are associated with management of this condition. And then finally also in the community too, because of some of these misconceptions. So a lot has to be put in terms of if we really need to control this condition with advocacy and education like you have ascribed to, alluded to. On the other hand is that we can't run away from the fact that there's truly a medical condition that needs to be managed. And oftentimes the real issue from what we have discussed previously are all bordered on the fact that either the symptoms are not well recognized or the capacity to make diagnoses, sometimes misdiagnoses, and a whole lot. But by and large, potentially it's a medical condition that can be treated. I hope I've answered the question, but I wanted to make a contribution because Dr. Mwanta and Dr. Bala had talked about management of these two conditions, and it's quite genuine. And you know, they talked about various kinds of inhaler. And I'd like to really re-emphasize what Dr. Mwanta had spoken of previously. The fact that the new trend right now really is as much as possible to use one inhaler. The reason being that when people have multiple inhalers, the tendency for them to adhere and comply to medication is really low. It's just like someone who you're giving multiple tablets to treat a medical condition, let's say something like hypertension or diabetes, they are not likely going to respond. They are not likely going to adhere to this medication. So even when Dr. Mwanta was referring to having 2 inhalers, actually, he was referring to the fact that you have the same inhaler that you can carry both around whenever you need it, and even to manage your condition. The good thing we have right now, and which is also a misconception, because most people are familiar with the traditional inhaler that we have around. And those inhalers, like Dr. Mwanta has ascribed to, the bronchodilators, they usually have blue color. So even when you prescribe the right medication to them, because they are familiar with inhalers that come in blue color that give them quick relief of their symptoms, they quickly go back to it. So while we're doing this, we must also educate individuals to know really that all the inhalers are not the same. And the idea really now is not for them to have 2 inhalers, just 1 inhaler. And like had been asked, if their symptoms are not frequent, they can use it whenever the symptoms, they sense the symptoms are about to strike them, or they're about to have an attack. So I'll just stop at that. Thank you very much.
All right, many thanks, Dr. Ako. You talked about using medication when you have an attack or when there are symptoms. And, you know, I don't know, for some reason, some people eventually abandon medication if they don't have symptoms, you know, for a long time. And, you know, the question would be, has the asthma disappeared? You know, is it possible to resurface after so many years or so long a period without any symptom or attack? And I also want to find out what the emotional and psychological impact of living with asthma is like in a country like Nigeria. Because when you see people with inhalers, when I was quite young in school, you know, other children who use inhalers, we looked at them as potentially close to death. You know, that's like the mindset of a lot of people, like, well, these people are unhealthy, they're not likely to live long. So speak to us about all of that.
Okay, thank you very much. I'll just start with the last question. So you see, asthma, there's a lot of stigma with asthma, and it should not be, because asthma is manageable. People live healthy lives even to old age. As long as you do the things your doctor tells you to do, you try to avoid those triggers, you use the recommended medication, you don't have symptoms. You'll be able to live a good life. You'll be able to live, your activity level is good. You'll be able to live a very healthy life. So these medications, as we pointed out, are very effective medications to control the symptoms. So even if you're not having symptoms, you can still use this medication. Then, if you think that you want to stop the medication, you don't stop on your own. You have to meet with your doctor, and they will arrange, because sometimes, most of my patients, when I see that the asthma is well controlled on a particular, we start stepping down on the medications. So it will get to a point that we say, okay, it's only when you are having symptoms, use it. So it's not on the patient to just stop automatically, okay, I don't have symptoms and stop. No, it has to be shared decision making. You have to speak with your specialists about it. So this medication, this condition is manageable. So there's no need to stigmatize anybody or to say, oh, this person is going. No. It's when it's not controlled, the symptoms or the condition is not controlled. That is where the fear comes about, because of the risk of it can be life-threatening when you have frequent attacks. It can be life-threatening and can also lead to death. Because you see, globally, there are about, let me just put the statistics, almost approximately 300 million people are affected worldwide with asthma. And it accounts for 450,000 deaths. So in context, like about 1,000 deaths every day worldwide. So it's still a major problem, it's still a big problem. So, but with proper education, with awareness about this condition, many people are able to live their life well to good old age. So it's not something that you should stigmatize anybody for, but you should support people or those that have this condition and encourage them to use their inhalers, which are very effective and safe.
All right, many thanks, Dr. Nwata, for your contributions. We'll pause here for a break, and when we return, we'll take the contributions from our viewers. Please don't go away. All right, many thanks for staying with us. Of course, we've been discussing managing asthma. And we've got some messages coming in, and we'd like to take some of them and get responses from our in-house specialists. Now, let me take this first one from Obi Charles Ikechukwu in Delta State. Thank you, my physicians, he writes. Yes, asthma can be caused by genetic and environmental factors. Asthma can be seen as manageable and hardly kills if promptly managed. Okay, that's a contribution. The next message doesn't have a name to it, but my son of 12 years has asthma, and we have been dealing with it since he was 6 years old. Please, what is the name of the drug you are talking about? I don't know who again was talking about the drug, but, and the last one from here, good morning, my friend. Okay, good morning. My friend experiences difficulty in breathing, noisy breathing, and chest pain due to cold, and the doctor gives him some kind of inhaler in the hospital and it's advised not to take cold things. But he is not asthmatic. Why? This one is from Annabelle in Port Harcourt. Now, let me get to Dr. Hassana, if we can hear her now, if you can respond to the two questions that we've got in.
Very clearly. So, if I got it rightly, one of the questions is about the name of the drug her young child is to use for his asthma, right?
Yes, please. Go ahead.
So, you see, children and adults, you know, who both have asthma, but they're treated differently. And then talking about adults, you know, not all asthmatics are being treated the same. There's a stepwise approach to treating asthma. So, meaning that, you know, for those with mild symptoms, you know, you start with step 1, as the symptoms progress. If they do progress, you know, you step up to step 2, 3, and 4. So for each step, you know, you have your inhalers as backbones, but then in addition, you could have adjuncts, you know, other medications as support, you know, that you could use, you know, as an adjunct in treating. So I wouldn't say there's, you know, not the manager of asthma is not one that fits all, okay? So you have to look at the peculiarity of the patient's age, the patient's severity of symptoms before you decide on the type of medication. So I would advise her, you know, to meet the doctor that's treating her child, and they sit down and understand each other. You know, she's to be taken along with the management, okay, and you know, should understand the management for that particular child of hers. Then the second question was about a patient being given asthmatic medications and then he's not asthmatic. Now, you tell patients, you see patients in the clinic, they come in for follow-up, you know, periodically, but they tell you that, you know, they are not asthmatic. Or you see a new patient, you ask the patient, for how long have you been asthmatic? Well, I've had these symptoms for years, but I've never been told that I'm asthmatic. So it all boils down to educating the patient appropriately. You tell them that these symptoms you have are typical of asthma. They typically have, you know, noisy breathing that we call wheeze, breathlessness, chest tightness, and at times cough. So if this is supported by, you know, presence of typical triggers, okay, and particularly if the symptoms are being relieved by particular medications, then, you know, all you need is just test to support your diagnosis. But the diagnosis is, you know, largely clinical, meaning from the symptoms and how the patient presents, you can, you know, actually say a patient is asthmatic. So as long as the doctor says the patient is asthmatic, then he should, the doctor should be able to explain to the patient, to his understanding, to clear all his ideas, you know, concerns, okay, and expectations about asthma, and, you know, he would own the disease. If you're asthmatic and you're being told that you're asthmatic and you think you don't have asthma, then there will be a problem in your management. You might not necessarily even agree with use of inhaler. Now, another thing is that depending on the patient's age, okay, and the patient's condition, there are other conditions too that, you use inhalers, but, it's not for discussion today. So if he doesn't have asthma and he's been asked to use inhalers, there are other few conditions like chronic obstructive pulmonary disease, or if he has something that, a condition that we call bronchiectasis, he could use inhaler. But then, largely, generally, the physician should be able to diagnose which condition the patient has and educate the patient on that condition so that the patient will own, the condition for better management.
All right, many thanks, Dr. Imam. Many patients in Nigeria would not want to own a disease or a medical condition, for faith reasons and all of that, religious reasons and all. That's a talk for another day. But let's read some more comments that we have right here. This is from Jack Alba from Makodi. It says, listening carefully to our experts, it seems asthma is more of hereditary illness. I became confused when environmental effect was mentioned along with few other factors. I have no choice than to ask, is asthma an infectious disease? I mean, can it be transferred? What's the difference between inhaler and spacer? Can inhaler be used as a preventive measure or only during attack? In case of emergency, will it not be advisable for the carrier to move with a tag so that the carrier can be helped? Like you write asthma on your forehead or something. All right, or maybe you wear a t-shirt marked, Anyways, the next one says, good morning, I'm Samuel from Delta State. I've been diagnosed with asthma many years back. I'm about 70 years old. Is there anything the Federal Ministry of Health is doing to help people living with asthma, especially for people like us in the rural areas? This one says, good morning to you all. I'm in my 50s. I discovered last year that I'm asthmatic. What could be the cause? That's Undem E in Lagos. Another one says, a child who has a very mild onset of asthma, who has been fine since birth, just irregular and often wheezing breathing at night and runny nose during cold weather. Does he need an inhaler or hand ventilator? And is there a medication that can help with it, as I do not want him to get used to the inhaler? Please, what do you suggest? That's coming from Lydian. Another one says, good morning, can asthma be cured? Ubibe from Port Harcourt seems to just join the conversation because that has been dealt with. We also have this one. What is the place of traditional herbs in the management of asthma? That's from Yusuf Abdul in Zaria. I'd like us to get to Dr. Ako, who joins us via Zoom. Dr. Ako, kindly respond to some of the questions that we have.
Let me pick the first one so that there's some clarity to it. We have talked about the people suffering from asthma. Actually, it's a combination of genetics and risk and some environmental factors. Now, the truth is that what we've observed is that not everybody that is exposed to some of these environmental factors come down with asthma-like symptoms or asthma diagnosis. Now, this then portrays something to us, the fact that there must be some inherent genetic input from individuals who eventually go on to have these symptoms that eventually will be referred to as asthma. Now, that has been discussed previously by the previous discussants. The fact that when people have this challenge, sometimes people have what looks like it, but in actual sense, they may not have airway inflammation. They may just have their normal allergies. People have just allergies normally, they may react to and so on. But there's no additional component of airway inflammation and so on that gives it out and suggests to the fact that they have asthma. So it's important that we take note of these. So put together for the person who had asked the question, while we keep emphasizing that atmospheric pollution like she has ascribed to and other environmental modifiers have been known to cause asthma in those who additionally have genetic predisposition. Having said that, the other issue really with making asthma diagnosis and misdiagnosis and all of that And then the issue of much later in life has been discussed previously. Now, like we said, there is a subtype of people who come down with asthma much later in life. We refer to those ones as adult onset or late onset asthma. But what we've observed is that a number of times it's as a result of exposure, maybe from the occupational environment. And so some people who indulge or are in some certain occupation, like Dr. Mwanta had listed previously, like painters, those who work in bakeries, those who work in chemical industries that produce fumes that are irritant to the airway, are more at risk to develop this form of asthma. Now, but having said that, Dr. Asana also brought another dimension to it for us to take note of. The fact that there are other diseases that occur in the later part of life, like she had given an example of chronic obstructive pulmonary disease, which we know presents similar way to asthma, but in actual sense entirely runs a different course. The treatment for it may look similar, but in these particular individuals, you're unable to reverse the airway challenge they have. So they go on to have the disease progressively, and at no time they may really get well till eventually they reach towards the end of their life. So it's important to note some of these differences and little between the disparity between in terms of early onset asthma that seems to be run with genetics and allergy, and those ones that we have that commonly are driven as a result of exposure from occupational sensitizers generally. I think I must have missed. What's the other question again that was asked?
Don't worry, we can take the rest here.
What's the place of traditional herbs in the management of asthma?
Wow. This is a tough one. But at the moment, of course, we know that some traditional have some anti-inflammatory property. But like we always say in the health clients, some of these claims can be subjected to more refined, proper scientific, evidence-based protocols in such a way that some of these claims can be documented. And while we cannot just discountenance the fact that there are some complementary or alternative form of medicine that may be effective, but what we're saying is that such claims should be subjected to scientific protocols that we can effectively really say that they work. But having said that, we know that the medications we have work. And the good thing is that most of the medications are safe. Like Dr. Asna said, in pediatric age group and so on. So parents really don't need to be afraid. Most times the fear of, I don't want my child to be on asthma, borders on some of these issues I've discussed previously. Stigma, people have some of these myths and disbelief. And that's why we keep emphasizing that education seems to be one important component, a non-pharmacologic component in management of these people. Sometimes it may be as a result of the fact that, of course, we being a religious nation by inclination, a lot of people would naturally not want to accept this diagnosis. And so it will not be surprising, but when we educate these people, we're able to overcome some of these. Now, I also want to add something to that as a rider to that. Now, it's important to note that these inhaled medications actually are safe. We keep emphasizing they are safe, they are safe, they are safe. Why? It's very simple. You have small doses of this information that are delivered to where really you need the drug to have its effect. A number of times, people are not familiar with use of tablets and so on. When you take tablet, it has to go through the bloodstream, and the fact is that it will affect other parts of the body. So you're more likely to have side effects of this medication than when you're using inhaled medication. So it's like a paradox, whereas people think we should not be on the inhaler, we should be on something like tablet. The opposite of it is the fact that the tablet will give you more side effects. So why go for something? It's like using a sledgehammer to kill a fly. All you just need is a little dose inhaled medication delivered appropriately, well used, and it's able to control the symptoms. All these other medications have their side effects,
Dr.
especially
Ako, thank you.
orally.
Thank you very much, Dr. Ako. Thank you very much for your contributions. Well, we have just a couple of minutes to go, and I'll take contributions from Dr. Enwata. Maybe in a minute and a half, if possible, your closing remarks.
Okay, so thank you very much for the opportunity. So asthma management is very simple, and we know that in the management is to control the symptom control and risk reduction for the patients. So when we talk about symptom control, we are saying that asthmatics, those are the people that suffer with asthma, they should have minimal symptoms. No, and these symptoms should not affect their sleep. These symptoms should not affect their exercise. Then when we talk about risk reduction, their lung function should be optimal. There should not be affectation of their reserve, their lung function.
Right.
Then there should be risk exacerbation, reduction in exacerbation, and a reduction in worsening condition that will lead to death, and also the side effects, minimal side effects. With all these medications they're going to use, minimal side effects to them. So when we see all this, you say, okay, this is the management. And then they should also involve the pulmonologists, the specialists. Doctors, that's why we say it about the awareness. To even health workers and other people, they should be able to identify and refer appropriately these cases, so that the proper diagnosis has to be made, and then management.
All right,
Thank
Dr.
you.
Bala, let's hear your final words on this topic.
So my final words, thank you very much for my final words is on health education and then involvement of the patient. We emphasize on patient-centered care, where the patient has a stake in the management, knowing what is wrong with him, having an insight in the disease, and then knowing the management steps. And then in training and retraining of staff, especially those in rural areas, that would be the first point of contact with the patient that present with this. So I call on appropriate authorities to ensure that training and retraining of our staff across all cadre in different parts of the healthcare system.
Finally, what advice would you give to families caring for someone with asthma?
So my advice is to give the patient the support that the patient needs. And if it's a child, educate the child on the triggers also. If it's an adult, support in various ways, financially, emotionally, and whichever way they can support the person, so that it will be a holistic approach to it.
All right.
Thank you very much.
Thank you very much, doctors, for joining us. Dr. Nehikai Enwata, consultant physician and pulmonologist from the University of Abuja Teaching Hospital, Gwagwalada. Thank you for being our guest. Dr. Ahmed Sani Bala, Department of Family Medicine, FMC Abuja, CEO of Vital Aid Medical Foundation. Thank you once again.
Thank you for
Always a pleasure. Alexander Agada Ako, Associate Professor of Medicine and Consultant Physician, University of Abuja and University of Abuja Teaching Hospital. Thank you so much, Doctor, for being our guest. We appreciate you sincerely.
Very much.
All right. Also appreciating Dr. Hassana Abubakar Imam, consultant pulmonologist at the Aminu Kano Teaching Hospital. Thank you, Doctor. And we wish you the very best. Thank you for being our guest today. We appreciate you deeply.
Thank you. Thank you.
All right. Having 4 doctors, consultants, an associate prof. I feel like a doctor myself.
You're one. You're one.
That's Good Morning Nigeria this Friday. Thank you so much for watching. Live it locked on the NTA. I'm Ian Ray John.
All right, we did talk about a second topic which we were unable to bring to you. We'll do that some other time. We appreciate your time with us. I'm Victor Azu. Join us again on Monday.